Excellent. Okay, so again, thank you for attending and welcome to our session. In an effort to focus on appropriate care for older adults, we have two sessions lined up for this year. This first one focusing on polypharmacy and drug adherence issues, and the one in the spring, which I'll tell you about at the very end of today's session, will be focusing more on quality of life issues. So for today's session, again, I'm Dr. Brittany Howell. I am a faculty member in Population Health Sciences here at UAA, and I can see I have a number of health sciences students here attending. That's excellent. I want to briefly introduce our panelists before we get started. In no particular order, we have with us today Kathy Young, who is a board-certified family practice physician who's worked in Anchorage and the Mat-Su Valley since 1998. She's been serving our Medicare population exclusively for more than 6 years now and has worked at the Alaska Medicare Clinic, which is now known as the Alaska Regional Senior Health Clinic. This gave her the opportunity to see many very long medication lists and to see firsthand how challenging these were for patients and their families to manage. Kathy is now the director for the WWAMI School of Medical Education, Alaska's medical school here at UAA. She's actually joining us from an airport in Chicago, so I will call on her again in a moment. Other panelists with us today include John Holmes. He's an assistant professor of pharmacy practice and family medicine at Idaho State University. He provides consultative clinical pharmacy services at a federally qualified community health center and family medicine physician residency training clinic. His interdisciplinary teaching interests include quality improvement, evidence-based medicine, and appropriate pharmacotherapy in older adults. Also joining us today is Teresa Holt, who has been the state director for AARP Alaska for 2 years. Previously, she was the state long-term care ombudsman, and before that, the executive director of the Governor's Council on Disabilities and Special Education. She's worked in the social services field for 30 years, focusing on advocacy and systems change for elders, people with disabilities, and on special education issues. Last but not least, we have an older adult joining us to provide us a patient perspective. Danya Clements served as the Alaska State Director of the National Senior Service Corps for 24 years. She received her bachelor's and completed graduate work in the field of education. Danya presently serves on the Municipal Senior Citizens Advisory Commission and has served on several boards and commissions, including the Alzheimer's Resource of Alaska, Mountain Pacific Quality Health Regional Board, Abused Women's Aid in Crisis, McLaughlin Youth Correctional Center, Municipal Transit Authority, and others related to senior services. So we have an excellent panel of folks here with us today. And to get us started, I just want to reintroduce this idea of interprofessional education. We have a number of health professionals joining us here on this call right now. We have faculty, we have staff, we have providers, and not least of all, we have a number of students at UAA and across the country. So Gloria Burnett advertised this event to the national AHEC group. And so we actually have folks joining us, students joining us from all over. These are the wide variety of allied and clinical health professions that we have represented on the call today. We of course have nurses and physicians, we have family caregivers, direct care workers, physical therapists, occupational therapists, psychologists, social workers, pharmacists, psychiatrists, dentists, occupational therapists, and a wide variety of others. So today we're going to be talking about how we can all work together to address this issue of polypharmacy in our elder population. First, I want to introduce our older adult patient, Danya Clements. I'm going to talk a little bit about her, and then we're going to let her speak in a few moments. So this is our case study for today. Danya will be able to speak with us in a few moments. Her age is 87. Her occupation, as I mentioned before, involves a lot of things, including active volunteerism. She has a medical history of UTIs, dialysis, pericardial effusion, which is fluid buildup around the heart, cholecystectomy, which is a gallbladder removal surgery, multiple ankle fractures, and vein ligations, which is the removal or tying off of veins to prevent blood from pooling. She also has Parkinson's disease, high blood pressure, edema or swelling, and is a wheelchair user. So our patient presented in an ambulance at the emergency room with severe pain from an umbilical hernia. Her regular physician was out of town, and she's been taking several medications, including blood thinners. This new physician who had to see her in this emergency took her off her blood thinners and estimated when it would be appropriate to perform surgery. The patient bled profusely during surgery, requiring several blood transfusions. This resulted in an incredibly prolonged healing that required 7 months in a nursing home because it was too difficult for her husband to help manage at home. So thinking about our patient case study as we move through the rest of this panel, let's talk a little bit about what polypharmacy is. John Holmes?
Yep, so it's very important to really understand what we are talking about when we say polypharmacy. And unfortunately, there's actually over 130 definitions of polypharmacy, depending on whether you are in the inpatient setting or outpatient setting, depending on the patient population, or depending on the degree of number of medications that somebody is taking. However, for the most part, usually we use a definition of the regular use of 5 or more medications on a daily basis. With this discussion of polypharmacy, I feel that it's very important to think about the appropriateness of polypharmacy and individual medications. So although we talk in the negative light of polypharmacy very often, it is important to point out that there are times when patients are appropriately on many medications, and that's distinct from those that are on inappropriate polypharmacy. So in 2010, approximately 40% of community dwelling adults that were 65 years of age or older in the United States took 5 or more prescription medications on a daily basis. Again, our definition of polypharmacy. Importantly, 90% take 1 or more prescription medication daily. Next slide. So polypharmacy can lead to many complications, many of which we'll discuss a little bit more in a bit, but it can increase the risk of adverse drug events, increase use of potentially inappropriate medications, increase the risk of drug-drug interactions, increase the risk of medication non-adherence and hospitalizations, increase healthcare costs, and lead to poor functional and physical health status for patients.
Thank you so much. And so let's talk just a moment about what is the role of our physician provider in this issue of polypharmacy. Dr. Kathy Young.
Good morning, everyone, and thank you for having me. I'm a family practice physician, and so when I think about polypharmacy and drug adherence, I recognize very early on that the more medications you take, the more difficult it is to actually take them all. The more times a day that we make you take these medications, the more difficult it is. And the less clear you are about why you're taking them and when you should be taking them and what you're taking them for, the poorer drug adherence is, because people simply don't understand why they're taking them. So a lot of this comes down to the problem of patients being prescribed multiple medications, sometimes appropriately, and sometimes maybe not. So the more medications patients take, the more likely they are to make mistakes in how they take them. The less likely they are to know which medications they're supposed to take with food and which ones they're supposed to take without food. They're never very sure whether they can take them all together or whether there are certain medications that they should take at a different time. And that can have impacts on their care. The more medications there are, the more likely it is that at least one of those medications will have an effect on one of the other medications that the patient is taking, and not necessarily in a good way. This is what we call drug interactions. In the same way that medications can interact, you can have situations where a medication is going to have a negative effect on an underlying health condition. The commonest one I probably see is people who take Motrin and have heart failure, and their heart failure worsens, or their kidney disease worsens. And we call this disease-drug interaction. So the last piece I would think about is that every medication has side effects. That doesn't mean that everybody who takes a medication gets the side effect, but the odds of suffering a side effect certainly go up the more medications that you take. So we've got a lot of potential problems here for patients who are older and take multiple medications. So what do we do? Next slide. So this is really a team effort. And certainly when I worked at the Medicare clinic, it was very definitely a team effort. And this was everyone from the person at the front desk, either at the hospital or in the office, through the medical assistants, through the nurses, through the pharmacists, to the providers, to the healthcare aides. It took everybody to really make sure that medication lists were updated and were accurate. One of the most effective ways we found to do that was actually to do what we call brown bag. Ours was actually a green bag, but basically we had patients put all of their medications, that was all of their herbs, all of their supplements, all of their prescriptions, all of their inhalers, anything that they were taking, into a bag and bring it with them. Now, this only works if you actually sit down with them and ask, how do they take it? Why do they think they're taking it? Are there problems taking it? Are they getting side effects with this medication? And this was a very effective way of figuring out who was taking what and if they actually needed to continue taking it. But there are roles for people beyond the people that you think about in the clinic. I mean, dietitians are really important because a lot of these chronic conditions can be managed with appropriate food. Supplementing grapefruit, which can interact with a whole bunch of medications, can be helpful. I've received calls from dentists and dental hygienists who are seeing changes in the mouths of their patients related to medication side effects that the patients weren't even aware of. When a medication can be safely stopped in patients of any age, but particularly as patients get older, they certainly should be. If we can have one medication do the job or do multiple jobs, then that's also a very effective use of medications and sometimes limits the number that we need to use. I always think about ACE inhibitors, which are not only a blood pressure medication, but they also treat heart failure and they also help protect kidneys. So bottom line, this is a problem that takes everybody thinking about what the patient needs best. Thank you.
Thank you so much. So let's talk a little bit about the role of the pharmacist in this issue.
So again, I can't emphasize enough when we talk about these individual roles that we really are meaning this is a team-based approach. So it just so happens that a pharmacist or a physician or a nurse may be on that team, but really this is a team. So pharmacists historically have been kind of the medication experts. On the other side, depending on the setting of the pharmacist, they may or may not be able to do a whole lot of the management around those medications. But one thing that you do see is a role of the pharmacist, or the pharmacist having a role in helping patients identify and reduce the number of medications that they use, helping them ensure that they're adherent to the medications that they are on. In some settings, there may be a role of the pharmacist working with on that team with the provider and patient and others on chronic disease management and ensuring diseases are treated appropriately, and on preventing medication errors and adverse drug events, and overall improving patient outcomes. Next slide. More specific things that a pharmacist may be involved with is patient and caregiver education. Historically, the pharmacists were very accessible at community pharmacies or retail pharmacies. Now that has changed a bit with COVID and other reasons, but they are a resource. They may be involved with medication therapy management, where they actually do work with patients on identifying high-risk medications in older adults and trying to get patients off of those medications. Pharmacists are oftentimes involved with medication reconciliation, because they do have frequently, depending on the setting, the list of medications. But it may be even simpler things like helping patients fill pill boxes, or helping them with blister packs and maybe packing their medications for them. It also may be helping patients navigate their insurance coverage and having to switch one medication to another medication based on insurance coverage. And then finally, I don't think we can talk about polypharmacy and older adults without using the term de-prescribing. And pharmacists and providers and the whole team and patients really need to kind of reformat our thought about, well, really we should try to de-prescribe medications and get patients off of unnecessary medications that they no longer need.
Thank you so much. So we've heard at least two perspectives from some clinicians about how to address this issue. What role do senior and human services have on this issue? Teresa?
Well, so I just wanted to say a little bit about myself. So I support my mom with her medical needs and her financial issues. So that's sort of the perspective that I'm bringing is as a caregiver. She lives independently, but as I'll share as we go on, she's not able to navigate the medical system independently. So the first thing I did really want to just talk about, especially from the AARP perspective, is that drug costs are out of control. We have many, many seniors that we hear from every year who can't afford their medications. They have to choose between transportation and medication, food and medication, getting other medical care and medication. So anything you can do to help them reduce the cost of medication, it's really, really important. For example, I was at an appointment with my mom, and she had some liver failure, and so they prescribed a drug for her. And it took us 3 tries to get that covered by her insurance. And so at the beginning, she was paying $260 a month for that medication. So that's just really not possible for her on a limited income to do that. But it's also not possible for her to independently advocate with the insurance company to get the drug paid for. So I just wanted to share that. So anything you can do to help people find ways to either get their drug costs paid for, or, you know, if it's possible to have a generic version, helping patients learn those. There's several like online RX tools that people can use on their phone or their computer to find the best drug price. So any of those types of things would be really helpful. And anyone on the team can do that, whether it's, you know, the pharmacy tech, whether it's the nurse or the person, the biller person in the office, the doctor's office. Really, anybody can help do that. It really, you know, takes some time. So, and some persistence. All right, next slide. Some of the other things that I have found really helpful in being that care provider and supporting my mom are the fact that some of her providers put all of the information from her appointment and all the instructions in writing and give that to her as she leaves the appointment. Her memory isn't what it used to be. Sometimes when people talk, she gets a little confused. So to have that written information so she can go back and read that at home, that's super helpful. It's also super helpful if you put it in large print. So font size 14 is helpful, or larger if you're able to do that. And then, as Kathy said, we found it super helpful for her to just have all her medications in one place at home. And then when she goes to the doctor, regardless of the doctor, to take all those medications. And that includes all her supplements. When we were working through some of her issues, she wasn't bringing the supplements. And then we found out later that the supplements were counteracting the medications or causing some of the side effects. And so it's important to bring all of those. And I have to say that she goes in the Providence system. They are very good that every time we show up, they pull out the bag, they go through the bag. We look through everything to make sure, because she can't remember the exact dose, if the dose changed. She was at one point seeing 5 different physicians. And so it was very difficult to make sure that everybody knew what everybody did at the last appointment. And then really helping patients find someone who can support them. My mom, 3 years ago, she was on no medications. She didn't really have a doctor. She just went to the clinic, the senior clinic. And then I went on vacation and something happened. We don't really know what happened. She passed out twice, was taken in the ambulance to the doctor. She ended up with a cardiologist and a nephrologist, and she was going to the clinic, and she was having all kinds of issues, and she had her past cancer doctor, and she had some eye problems. And so everybody was prescribing medications. And it really took me being able to go to all those appointments and keep a running list and create a document for her that sort of she could share with the physicians about who did she last see, what did they do, what medications there are, those type of things. The other thing is that she was new to medication, and she was just trying to take it without a pill box, and it was really, really difficult for her. And then she said, oh yeah, I have a pill box, and it was, a 7-day, 1-slot pill box. And she had, at this point, she was on like 8 medications. And they had to be taken at different times of the day, and she could never remember and get it all organized. And so I was able to help her fill those pill boxes. But there's not always somebody who can do that. And then the other piece that is really helpful as you go into that to supporting family members or caregivers is allowing those folks to be able to attend the appointments by using telehealth. So, at one point she had 4 or 5 appointments every couple of weeks. And if I go pick her up and I meet, and then we go to the doctor and I take her back, that's 2 to 4 hours every week. Not a lot of people can leave work and do that. So we came up with a system. She got herself to the appointment. They either called me on the phone, or we did telehealth using Zoom or Skype or one of those other things. And then I did just want to reiterate helping patients find and learn online tools. So there are also some apps and other things that people can use to do pill reminders, those type of things. And then the last piece, which is, I think, really important, and this is especially for folks leaving the hospital and going to home, or leaving a nursing facility and going to home or to an assisted living home, is whoever that supporter is, or the person who's helping them, make sure that you share the information. And if, so for example, say someone had a stroke, and it was the husband had the stroke and the wife is going to be the supporter. When you're doing the discharge instructions, actually, if the wife is going to have to assist him to stand, actually have them do it and practice. Because just giving them verbal information, a lot of it gets missed because they're stressed and their memory isn't as good. Writing it down is better, but if you can actually have them show you, or have them do it for you so you can see that they know how to do it, that is the best. So thank you.
Excellent. Thank you so much. So we've heard from some clinicians, we've heard from sort of the senior service perspective and Teresa's own personal experience as a family caregiver. But now let's hear from Danya Clements, from an older adult who's had some of these experiences herself. Danya, are you ready to share a little bit?
Yes, I am. I feel very unqualified to do this.
Go
I
ahead.
guess the only thing that qualifies me is I am an old woman and I do have multiple ailments. I'm sure you've heard this statement, never say how are you to a senior unless you have an hour or two to spend. But we're not going to go over the ailments today. I'd just like to share some things with you that I've found important in dealing with doctors. We came to Alaska in the 70s, and there were very few doctors who treated seniors at that time. Most of the seniors went to Virginia Mason in Seattle to get their healthcare needs met. However, things drastically improved, thank goodness, and we began to get more and more clinicians, and a lot of specialties. This went on for a while, great success for the geriatric community. However, suddenly, I think doctors began to realize that Medicare wasn't too good to deal with, and they began to drop their older patients. We're going through that right now, I think, with a lot of older people unable to find a doctor who will take Medicare. And Medicare is vitally important for the team approach to have a primary care physician and then specialists to treat the other needs. But I think things are going to be on the upswing. Let's hope. But when all of this happened, I had a doctor for 15 years and I had to go looking for another doctor. I made 63 phone calls out of the phone book to see if I could find a doctor who would accept Medicare. And I tell them I'm a grandma, and if they said they wouldn't take me, I'd say, well, you can't call yourself a family physician unless you treat grandmas. And several got that message, I have to tell you. But I think that looking at the way things are now with a primary care doctor and specialists, this team approach is what saves us all. I'm very grateful for the team approach. I think the pharmacist and physical therapists, so many people involved in our care, but we have to be very careful when you're looking at an older person and all of their many ailments, that you don't just refer to them as the gallbladder or the broken ankle. I am a person and I have a name. And I'd like to go through some things I think are important when you're dealing with seniors. Teresa did a wonderful job in explaining about her mother. And I was saying yes, 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 yes to almost everything she said. And these are just a few other suggestions. First of all, when you're going to see somebody, know their name. I can't tell you how many times people have come into the room where I'm waiting and have a pile of files and start looking through and say, let's see now, you're Mrs. I realize my first name is hard to pronounce, but I do have a whole name, and you should know before you come into the room who you're dealing with to give us a little confidence. Then the other thing is to look me in the eye. I sit there and look at the doctor or the pharmacist or whoever, and they're looking at the computer and they're typing at the computer. And I know this is necessary to do, but please recognize that I am there and I want you to see me. I think that just goes without saying, but I'm going to say it anyway. Then I'd like you to realize that when a person has a caregiver, they are just that, the giver and the caregiver, but they're not the patient. The patient is the person you need to talk to. It can be so easily overlooked because I'm in the wheelchair, I'm sitting down low. But let me give you a little story about how impactful this is on me. I had a UTI, which is quite common for us old ladies, and went to the urologist. They wheeled me into the room with my daughter was wheeling the wheelchair. The nurse followed her, took the plastic cup, reached over my head, handed the cup to my daughter and said, "Do you think she can give us a urine sample?" And here I am sitting right there. I raised my hand and said, "I'm the one who's going to do the peeing. I'm here." But that's just an example of how you get overlooked. And I think it's very important that you realize the patient is the one who has the problem and you need to speak to the patient. Then the other thing is when you're examining or giving directions, to make sure that you are speaking directly to the person. And I think Teresa gave a good example of making sure that everything is written down. That's so important. It's hard to remember. The trip to the doctor's office is often quite traumatic just to get there, let alone what follows. So make sure that you're speaking to the patient and make sure they've heard what you have to say. I think a lot of seniors are very good at saying, okay, okay. And you say, did you understand? Yes, yes. And they may not have heard you. So Teresa's suggestion of having a list when you leave the office is very, very important because we often don't remember. But the other thing that I think is vitally important is that you listen to the patient when you're interviewing them. Yes, you're going to have suggestions for their care, but listen to what they say. I want to give you an example of how not listening affected me. As you were told, I broke my ankles and had to go into a nursing home because my husband of 63 years could not take care of me at home. This in itself was a traumatic experience. But when it was time to go home, the physical therapist was going to go with me to walk through my being at home to see how I would manage. Well, it happened to be raining that day, and so the entryway to my house was kind of wet, and she said, let's go use the steps in the garage, which I had not done practiced before. They were 7-inch steps, and I said, I can't do 7-inch steps. And she said, oh, yes, you can. Let's give it a try. I can't do 7-inch steps, but I kept looking up the steps and through the door and saw my African violets in my kitchen and said, I will. Okay, we'll do it. Well, I didn't make it. I got to the top of the steps. I fell and broke my other ankle. I was back to the nursing home for another long period. If she had only listened to me when I said, I cannot do those steps, but no, I wasn't heard. That's just one example of how important it is to listen to what the patient has to say. Then I'd like to talk just a little bit about the other health partners and working with them. Teresa has said that she's with AARP. We also have a senior newspaper. We have a resource, Aging and Disability Resource Center and the Senior Center that can all help go beyond what might be the physical needs of your patient. And I'm not saying that the physical needs should be slighted, but if the team approach, you look at the person as a whole. They are a whole individual. And there are lots of things in our community that can help with this. I want to tell you a little bit of an example of how impactful it is to work with others who are working with seniors. I had a doctor give me a call when I was director of the National Senior Service Corps one of the things that was required for the Senior Service Corps was a physical examination for each of the elders that were in our program. So I was looking for doctors and acquainted with a lot of doctors in the community. And I got a call from this doctor who asked me if we could use a lady that was one of his patients. She had come to Alaska because she had terminal cancer. She wanted to be close to her son, but she was still semi-active and wanted to be with children. So we placed her name was Ida. We placed Grandma Ida in a first grade classroom. Now she was taking multiple medications, but none that would inhibit her from doing this daily service. So every day she went to the first grade room, and worked with these children. One of the requirements, as I said, is a yearly physical examination for each of the seniors. So she passed her physical and worked with the children every day for over a year. Time for her next physical exam, she passed that one. She passed the next one and the next one. So what was a terminal cancer diagnosis was put off for many years because she was needed and she was welcomed into the community and was somewhat of a miracle. So I could sit and tell you story after story about how not just the medication and not just the doctor, but how being seen as a whole person is so very, very important. And I'm going to wind down now, but I wanted to tell you a couple of other short things that I think are good for you to note. First of all, if you are meeting with the seniors, try doing just a little play acting. Put yourself in a wheelchair. See how easy it is to get into the office or not easy. Sometimes it takes 3 people to open a door and get a wheelchair through. Go through the whole environment in your office to see how friendly it is to seniors in a wheelchair or with a walker or with a cane. Sometimes it's just placement of furniture that makes the difference. Then it's important for your own well-being, I think, to reach out. Sometimes just make a telephone call that isn't connected to their care, just to see how they're doing. I know you're very busy and this sounds like pie in the sky, but I would like to tell you about a call I got from my pharmacist. We had changed pharmacies because of the COVID. We wanted to be able to pick up medicines in the drive-through. And I got a call from the new pharmacist, not about my medicine, just to see how I was doing. He called to see if there was any questions I might have and how I was doing. Believe me, I would not change pharmacies for the world just because he cared enough to give me a call. And I think that's the thought I'd like to leave you with. You care about these people or else you wouldn't be in the helping professions that you're in. So let them know that you care by doing some of these smaller things that may not seem clinical, but I think are so important to our care. And thank you for all that you do.
Thank you so much, Danya, for your stories, your experiences, your vulnerability, and your tips. Really great advice for our future and current clinicians and social service workers and support and family caregivers. I think that this has all been really helpful information for us to slide into some small group work time. So we are going to be getting into some breakout sessions that are interprofessional. So our behind the scenes staff has been looking at students in different areas to be sure that we're crafting some breakout groups that include a wide variety of professionals. And in these small breakout groups, we're only going to ask 2 questions, but they're going to be pretty in-depth about how teams can manage this difficult issue of polypharmacy for older adults. After our small breakout groups, we'll get together for a larger debrief of what we discussed, and then we'll have 2 more questions for the larger group to consider and think about. Hopefully we'll have a little bit of time at the very end for some Q&A with our panelists. So I think I'm passing this over to Gloria to let us know how things are going with the breakouts.
Yes, I am ready for you all. I've learned my lesson and improved from the past. So we are looking good. I did my best to make these as interprofessional as possible based on who is actually here. I know a lot of people registered, but it's a different story with who attended. So it looks like our sessions will have between 5 and 6 individuals per. I'm going to open up the breakout rooms now. If by any chance you don't get assigned, we will be here in the main room to make sure that we get you out where you need to be.
Gloria, can you remind us approximately how much time we should be in these small groups?
Well, we usually leave about 15 minutes for each, but looks like we have extra time, usually things, you know, depending on how much time we have. So looking at the clock now, I'll make sure to give everybody a warning before we close the room so you'll know it's coming. You'll have probably between 15 and 20 minutes.
Thank you so much.
In that range.
All right, hang on, folks.
Here we go. You can go ahead and accept your invite, and then it'll send you directly to your breakout room. And there's some that I'm going to have to pre-assign, so I'm going to work through those right now. Lisa, I believe you have to leave early. Did you want to go to a breakout room for now? And then also our panelists, I'll give you the option if you'd like me to assign you to a breakout room just to observe, let me know.
So Gloria, this is Kathy. You sent me to 9, but what are the 2 questions, or who knows what the 2 questions?
I am going to pop that in the chat box. I'm going to drop into the rooms and do that. So,
okay.
There is usually a way. I wonder if I can do this. Share screen.
I think you can broadcast it to each of the rooms.
I don't know if it lets me do that. I can only broadcast a message. I must not have the most recent version of Zoom because I saw someone do that the other day and I was pretty excited about it. Doesn't look like I have that option. So I'll put it in the chat box. You guys can have that. And you can just download it. There it goes.
Gloria here? No.
Well, to my team, I thought we'd got given a 1-minute warning and had to return back. Maybe I brought us out of our group a little bit earlier than I read. I'm sorry for that.
That is okay. I'm just chomping away on my lunch.
Oh, good. Yeah, everyone definitely make sure you don't skip lunch because of the grand rounds. We definitely don't want that to happen. Dr. Howell, I was a bad facilitator and I misread and I thought it was a 1-minute warning. So we jumped off a little early, but we still had a wonderful chat with our group.
That's okay. I actually didn't see how much time was left on my warning myself, and I just kept going as well. Gloria, do we have much time left, or how should we proceed?
I don't think Lori's back on yet.
I think what I read is 12:15, 2 more minutes.
Hello, everyone. Welcome back. Some of you might already be back. I wanted to apologize. I'm so used to being on a time crunch that I just thought we had 15 to 20 minutes, but we had more time for discussion, which is a beautiful thing. So welcome back, everyone. And we will now be moving on into our large group debrief.
Excellent. Thanks so much. So the first question we were talking about is just sort of the various roles that we may all play in providing elder care, particularly with this issue around polypharmacy. So do we have any sort of group leader that would like to share a little bit about how your discussion went?
I think my group was group 1, but I'm not positive.
That's okay, go ahead.
So does anybody want to, we didn't pick a leader, but Amanda, Anna, any of you want to speak up? No.
That's okay. So we don't have to go through every single group because we're probably talked about a lot of the same things. Let's put a hold on group 1 and go to Kristen Bogue, who has raised her hand.
Sure. Yeah. Our group we had a great mix of health science and allied health and graduate level clinical students. So it was fantastic. And the students all together, we kind of talked about what were the other roles that hadn't been mentioned yet. And so a lot of great things came up. And what I think I really appreciated there was a focus both on the kind of your traditional health roles, like your nurses, but in even your rehabilitative sciences like OT and PT, but also the social services side. So we talked about social workers and health educators and public health professionals in there. Something else that was brought up, which I thought was really powerful, was the role that dentists can play, especially dental offices. If we have somebody that might only seek out services maybe once or twice a year, maybe it's only their vision exam, or maybe it's only their dental exam. It was brought up like just doing vitals at those offices can have a huge role, because if they catch something or have a red flag, then they can get them connected with a provider. So yeah, it was a wonderful discussion. I think we didn't definitely address all disciplines, but try to focus outside of what had already been mentioned.
Excellent.
I was in group 3. If we could just roll on. Okay. So I was in group 3. We had, I believe, some nurses, pharmacists, myself as a social worker. I think the big question was the dentist, the hygienist, how they play a role. And unfortunately, they are put on the back burner, and that's brought a lot of light to me, which has helped. And I'm sure everyone else in my group of how important it is, and how some medications do affect the dental hygiene. We talked about collaboration and the teams, and how it is important for teams to get together. And as for my perspective, it's more of, like I said, in the group, it's a great idea, but I feel like it needs to be implemented a little bit better. And I know a lot of people are just starting on teams, but hopefully it could kick off to where we're hoping it to be at. And if anybody else in group 3 wants to chime in.
Well, I was the pharmacy student in group 3, and I shared that I have a long background in long-term care pharmacy as a technician, where the bulk of our patients were elderly who were in assisted living homes, or if not, they lived on their own, but needed the help in managing their medications because they are on so many different medications. And so the role that my pharmacy took, in which I'm very proud of, they were very, very on top of medication reconciliation, since this population does come in and out of the hospital frequently, which can lead to some poor outcomes for them. But just the importance of MedRecs, the main hospital here in Anchorage, Providence, it was very, very good. The pharmacy is very good about calling for MedRecs upon the patient coming into the hospital. Very good at the pharmacy I worked at medication reconciliation when they got out. And so felt quite privileged having the time that I did there to learn about polypharmacy with patients. I did say I was privileged to have worked in this setting, but there are the retail settings where this isn't implemented as easily, because our patients are seeing so many different doctors. They may go to multiple pharmacies. And so just trying to come up with solutions in those settings as well.
Any other groups like to share some of their discussion?
This is Darcy, and I was with group 6. And I think that Gloria did a great mixer-up job. We had a nursing student, a PA student. I think it was PA, he was in something else, but he's going for a PA eventually. And then 2 dental hygienists. So it was a pretty good discussion. I'm just going to mention a few points, and then maybe they can jump in if I've missed any important points that we were talking about. And these are a little bit more specific as far as thinking about the brown bag experience. And you're the one of the members of the team that are going through the brown bag. We don't want to assume that the doctor before you or the 5th doctor on the team has done the brown bag already. So it's important every single time to go through the medications. That was one thing that was said. Another thing that was interesting, I thought, with the dental hygienist, she mentioned that she had this experience, and I don't know, maybe you want to say yourself, but when she would call the provider about a pre-order for an antibiotic for a patient that was coming in, how she got this comment that was, why do you dental hygienists call about antibiotics all the time? What's that all about? So, just the idea of, she didn't have time to share the whole story, but nonetheless, there's a lot of lack of knowledge around the team members or the parties that are involved. So, it's okay to take a little time and share what it's all about. And then one of our other participants mentioned about the home setting and how maybe a question or two about the home setting could be important for elder care, not only as far as mobility goes, but where do they keep their medication? Do they have the same place, the same time? How is their lighting? How is their vision? Things like that are related, a little bit remote, but nonetheless important. So thank you, team. I think we did okay. Did I miss anything? All right.
Well, Darcy's a hard act to follow. Great job. But I'll just report out a little bit on what our group talked about. So we had also a nice mix of some dental folks, some pre-med and nursing. So we talked a little bit about what it looks like in each of those environments or roles when we're looking at ways to prevent errors. And so we talked a little bit about this cheese model and how working as a team allows for kind of layers of knowledge and checks to make sure that we're providing good care when it comes to prescriptions and everything else. And so we talked about ways that we can educate our clients about compliance and side effects and the use of tools like Hippocrates and micromedics and drug guides and things like that. We talked about our programs and kind of what is involved that helps prepare us as clinicians to, educate different groups of people. And so, today we're talking about elder care. And so there's some specific things to consider. So we had a great conversation about, maintaining, decorum with a client and making sure that they feel respected and heard and all of those things so that the education you're trying to provide can actually be received by them, that you're not putting up barriers. So that was a good conversation. Let's see. I think that kind of summarizes. What else? Did I miss anything, you guys? I don't know. It was a good conversation.
It was, and Angela was the team leader for my group. I think you summed it up pretty well. The team really wanted to talk a lot about how to form teams, because we realized that in nursing homes or assisted living, or maybe in a hospital or at tribal health, teams exist or teams are easily facilitated. But for the most part, when we go to a physician and get a referral and get a referral and get a referral, these people are not part of a team and they're not actually interacting together. So we talked a little bit, maybe that segues us into our next question. We talked a little bit about what would be the benefits of such a collaborative model and how can we get there? What are the sorts of things that can help facilitate team-based patient care in a system that seems to be very broken up into separate components? So I'm not sure if anyone else talked about such an issue, but what teams would like to report back on this question or that issue?
I can share it on my group a little bit. I don't remember our group number, but I was with Professor Bogue. So we talked about the ability to ensure that you're providing the best care possible for your patient in that interdisciplinary team. Discussions around, certain medications might have an impact on specifically trying to think how to phrase this, the stability or the structure of the jaw and the bone composition, but it's a medication used for osteoporosis. So if you have someone on your dental team that's able to identify, hey, this person already has some issues, maybe there's complications with like a wisdom tooth removal, they have some structural damage there already, maybe there's a different medication we can prescribe to help them with their osteoporosis. There was another discussion around kind of the idea of a warm handoff going from primary to secondary to tertiary to home care, and reducing some of the stress and anxiety on the patient of not knowing who their next provider is and what that treatment's going to look like, for them to have a more smooth transition between all those different phases and get them back on their own. If anyone else wants to jump in, feel free, but I think that's what I remember most from our discussion.
Yeah, I'll add one other thing, and I think it was Mackenzie that shared it, was about how you can utilize interprofessional teams to help with some of the work balance as well, because we all know, for example, right now, pharmacists are overworked and understaffed, and they can't necessarily give the patients the amount of care they really want to. So thinking about how you can lean on other members of that team, I think it was Mackenzie that brought up the fact that the nurses might be in a good position to really listen to the patient's story and bring, certain highlights back to the larger team to say, hey, is there anything we can address with this one? So yeah, we just talked about that, leaning on your team to help with some balance.
And also we talked about how working in a multidisciplinary team, how it gives us the opportunity to network and build those everlasting relationship. And also, that all together can essentially help the patient and improve their care.
Our group discussion, sort of just to kind of spin off of Kristen about what you're just saying about that balance of time. Kind of the end of our discussion, we started talking about, how do you balance? They've given me, I'm required to see this many patients in a day, but I want to provide quality care. I want to have that connection and communication with my patient or client. And how do, and I think Shana, who is one of our dental hygienists, was talking about how she doesn't want to lose that. Like right now in clinic, she's been given a lot more time than she knows that she's going to be given, kind of maybe in the real world, so to speak, and doesn't want to lose that ability to communicate and listen and everything. And so we talked about that time balance. And also then, as far as the interdisciplinary team goes, thinking about, does everybody know what your role is and that it's okay to communicate with another person? Hey, especially like providers, a lot of times only do get 15 minutes, and to share what your roles, what your scope is, what your skills are. And gosh, I can help support you because I have an hour, and we can, and making sure that the entire interdisciplinary team has knowledge of what our individual roles are, because we're really discussing that here as students, but in the real world, so to speak, that lack of knowledge of what the roles are is very prevalent. It's there, it's real. So anyway, so we had a great discussion.
Thank you so much. Angela, were you about to say something?
Oh, I was just going to add just the idea that I had mentioned during our discussion was, I think I'm probably a little idealistic being a student and looking from this perspective, but I just mentioned like how shocking it is how much paper we still use, and we live in 2021, and just, I would love to see, and I don't know whose calling it is, but I'd love to see, for healthcare professionals all to get on the same page electronically. I mean, how amazing would that be if information could be shared directly and more easily across, your nephrologist to your family practice to, whoever needs to know what meds these people are on and what their background and their history is. So I don't know if we'll ever see that in my lifetime, but hopefully.
Great perspective, Angela. We're all hoping for that. That would be, when electronic health records became a huge thing, you would think that would be much more prevalent right now. But unfortunately, when everyone's using a different system, it doesn't really work out that way as smoothly as we would like to see it. But that's a great point.
Hi, can everyone hear me? Awesome. Hi, this is Liz Swanger. I'm a pharmacy student. Something that I just wanted to say that I feel like a lot of our discussions and what we're talking about, I just want to remind everyone that we, in all of our efforts and all that we do, especially with this transition of care between the interprofessional team, keep in mind that this is advocacy. This is advocacy for our geriatric patients a lot of the times where they may not have that in their system or be able to advocate for themselves. And I think it is just so awesome that we are able to do that as professionals and be able to navigate the system that we know kind of on their behalf and in creating better outcomes. Thanks.
Thank you so much for that perspective. Our group touched on that a little bit as well, as far as what patient advocacy truly means and what it can look like, because a lot of clinicians are looking to meet certain metrics for quality of care, and that might be discharging as soon as possible, and that is not necessarily in the best interest of our patients. Additionally, what patients actually want to pursue, which medications or procedures they're willing to undergo, are not always the same as those that are being recommended by clinicians. And so it is so important to really listen and allow people this right to refuse or change certain procedures. We tend to be trained on how to provide medical information and care to Norm. Norm is a 35-year-old white man. This is how we tend to get our medical education. We don't always learn how to interact with children, with babies, what pediatric information looks like, and we very rarely learn how to interact with geriatric patients. And that can be very different, to listen to them, to ensure autonomy, even if they're in a wheelchair and it doesn't look like they're capable, but to assume that they are.
Brittany,
excellent.
I saw that you put something in the chat. Could you elaborate a little bit more about your Swiss cheese comment, your Swiss cheese model? So, and I don't know if you were referring to patient safety or what, but.
Yeah. Yep. So, yep. So one of the groups reported back just a minute ago on the Swiss cheese model of medical errors. And that's definitely something that future clinicians should look further into. If they haven't heard of this concept, It's something that we sometimes learn and sometimes don't learn, but it's essentially a way of thinking about how medical errors occur in a variety of settings and the safeguards that we have set up to try to eliminate them, and that IPE and interprofessional teams provide a lot more checks and balances for ensuring that those medical errors don't occur. It's called Swiss cheese model because we're thinking about a block of Swiss cheese with some holes in it. And very rarely do those holes go all the way straight through the block, right? They're just sort of little half holes, right? And that's because if we think of a medical error entering that cheese block, there's someone there to stop that error from occurring. And then there's an error coming in here, but there's someone there to stop it. But occasionally that block of Swiss cheese does actually have a hole that goes straight through it, where all of these different clinicians have missed something. And so it occasionally happens, but you know, I said to my group, Swiss cheese is just delicious. And so it's a great way of visualizing and thinking about how medical errors can occur. But it is a term that's often used in med school. So if we're not there yet, it might be something you'll get to hear about. And then of course, Logan mentioned the warm handoff. These are sort of buzzwords, terms, important concepts to look into if you're unfamiliar with them. So if we are okay moving ahead, that was a really great discussion. I think we're pretty solid on what the benefits of team-based work is and where we have future work to do to ensure that that team-based work is actually occurring. Let's think a little bit more as sort of a larger group about what disciplines you might have been exposed to today that maybe you hadn't previously considered as having a role in polypharmacy or elder care in general.
I stepped in and was facilitating a group where we didn't have a facilitator. And it always comes to mind, and we actually had a comment from one of our pharmacy students that the value and the role of dental hygienists, these IPE events really help them understand that impact. And you're seeing your dental hygienist quarterly many times. They know you, there's a personal relationship established. You notice things that maybe the average physician might not notice just because they don't see you as frequently. So we really kind of honed in on that concept of what they might notice and what referrals they might be able to provide accordingly with that relationship component.
I can definitely second the newfound knowledge and appreciation of dental hygienists in the role of healthcare providers, especially with our group talking about, as Professor Bogue mentioned before, taking those vitals and having an opportunity to just do a really basic, quick once-over, especially that individual's, annual time they seek medical care, and it's the only time that we're able to capture that information. I think it's really important to pick up on some of those red flags like blood pressure, things like that, before they progress to needing a higher level of care.
I think Sean had raised his hand. Sean?
Great.
One thing I noticed that we haven't talked about, that a role that I think can provide a lot of insight and more depth with like patient care time is CNAs and PCAs. They spend a lot of time with patients and get a lot more information than anybody else does in general.
Great point. Yeah, thanks, Sean.
What I really like about Sean's comment is that he's helping us step outside of what we consider a clinician or a clinical encounter. So let us not forget the social workers, the senior services, the human services, the variety of other social services that come into this, and direct service providers, family caregivers. These are all people that can be part of these clinical encounters as well.
I guess I would just add to the point that Gloria made that, and she was talking about dental hygienists seeing people quarterly, but any role really that establishes a relationship and knows somebody is probably going to be more sensitive to changes. And sometimes the first thing that we see with health problems and polypharmacy might just be that they're off. They're not themselves. And so you don't have to be a rocket scientist to pick up on that. But if you have a relationship with people and you're, observant, you're going to see that and be able to be that first line of, that brings it up.
So relatedly, what are some takeaways from this event that you think you might be able to utilize when you are, a licensed and certified practitioner, or maybe you already are? I don't want to neglect the fact that many of you are already working in healthcare and are bringing incredibly rich experiences. But maybe some folks can help share some takeaways from today's session.
So one thing as a pharmacy student that I take away from this is that it's really important to have that interprofessional aspect and just being able to collaborate, and also listening to the patient and not dismissing what they want as part of their care, and actually making them a part of their care, because it is their care. So just being able to listen and respect them no matter what age they are.
This is Anita. I'm a student with WAMI. I think we get very caught up in like the clinical encounter and like, okay, what is this patient's diagnosis and what medications are they taking? But I think at the end of the day, our goal is to really like empower our patients and empower our caregivers. So really it's about maybe, being on the same page as our patients. So we might know what medications they need to take and how much they should take it, but we want to ensure that, our patients and our caregivers are also on that same page, that they're equipped with the right information to make their healthcare decisions. And really, really arming them with that information so that if they have to go elsewhere, like they know basically they have some exposure to how to navigate the system and they're not totally lost.
Thanks, Anita. That was really well said. And I think from our group, Dania said she wasn't an expert, but she was the star. We all really, really gravitated to what she shared about herself. And every single time we do grand rounds, this is exactly what comes out of it. Without that patient perspective, these sessions just wouldn't be as valuable. So I just wanted to give her some kudos and thank her again for sharing her experiences, because that really does impact our future healthcare professionals that are in this room right here on Zoom with us that are going to be providing care in the future. So I just wanted to provide that reinforcement that Dania, your perspective is very valuable and you were an expert on our panel. So thank you so much for being a part of this today.
Thank you, Gloria. Thank you.
Yeah, and I really, really appreciate what Dania said at the end in regards to her pharmacist just taking that moment. It's just, it's important just to follow up with a phone call. Hey, how did that go for you? And that really helps to establish a relationship that's even stronger between the patient and the provider, which whatever that provider might be, and a sense of trust, that she can trust in coming to this person with whatever's going on and trust that that person's going to help look out for them. So the relationship and the trust.
True, Emily, very true. Thank you.
Thank you all so much for sharing. I want to take these last 15 minutes or so and open up the room for questions. So I think we still have most of our panelists on the call. Do folks have anything that they would like to specifically ask Dr. Young, Dr. Holmes, Teresa Holt, or Dania Clements before we close out our session?
Kristen.
Yeah, I had a question regarding, I think we've all addressed this today. I know it came up in our team about, just especially during the pandemic, folks are kind of overwhelmed and just treading water at this point. But for the panelists that joined us today, for those of you that are clinical providers, what is it that we could do, as an academic institution to really support your efforts, to kind of see the ability to be able to collaborate more frequently to meet the health of our communities?
Well, I'll have a stab at it. That's a huge ask. I think probably the biggest single thing is, and we talked about it in our little group, is communication. I think being willing to pick up the phone and reach out and call the doc, or reach out and call the dentist, or reach out and call whoever it is. Frequently, caregivers know more about what's going on with the patient. And so if they seem off and you're not getting answers maybe from them, or you're worried about them, then checking in with the rest of the team. But keeping the lines of communication open is probably huge. And keeping the lines of communication open with patients is the other big piece.
Kathy, is there anything in particular, though, like the UAA as the academic institution, the main hub for College of Health, is there anything you think from the academia side that we can do to support these efforts?
I think, so we used to do an SBAR simulation with PAs and nurses and medical students and nurse practitioners. And I think more activities like that maybe incorporate a wider body of students, so that students get used to talking across the professions, would be helpful. Informal, structured sort of reporting. I have Mr. Jones here, and this is what he has, and this is the background, and this is what I'm concerned about. And, if you're in a position to give a recommendation, that's great, but so that everybody's speaking the same language. So maybe if every graduate came out knowing what an SBAR was, not just nursing students. Just a thought.
I have another thought. I agree with the communication one. I think the other one that we've seen really rear its head out there is just the burnout that clinicians have. And so I think from an academic side, really as we educate students, thinking about what tools and tips and tricks can we give students so that when they do graduate and they're faced with a similar situation like this, they have those tools to deal with the burnout that may come in those instances. So I think that'd be something as well.
I'm so glad you brought that up, John. And I have to jump in here and preview for you all, students that are here, faculty that are here. Our office at the AHUC program is working on some resiliency curriculum and training that we want to roll out. We have applied for a HRSA grant that we should be hearing any day now, because it starts December 1st. So send all the positive vibes our way. That will help fund training across the bar for not only our current healthcare providers, but more importantly, as John is talking about, in order to really transform the culture of burnout and compassion fatigue in the workforce, we've got to start teaching you all as future providers to be practicing this in your own life. So this grant proposal involves a component, which AHEC scholars on the line, this could be a great opportunity for you if we get it, where we will train our AHEC scholars to train other students on resiliency types of self-care techniques and skill sets to embed within your practice, because it's part of your practice. Taking care of yourself is part of your practice, but we don't talk about it enough. So I completely agree with John, and keep sending your positive vibes our way, because if we get it, we are rolling this out quickly, and we will be reaching out to all of you with the prospective opportunities that will be underway.
This is Darcy, and I currently moved into this new position as the interim director for the College of Health Interprofessional simulation center. And certainly IPE, interprofessional education, is a good way to, along with sessions such as we're experiencing right now. But I want to just piggyback off of Dr. Young's comment about SBAR and how, you know, it would be really easy for a couple of professions to get together and do a sim in the center or with a sim staff and practice that SBAR over and over and over again. Pretty easy to do, probably low time involved, and we're just sitting right there waiting for these kind of opportunities. Thanks. That was a little bit of an advertisement, I guess.
Any other questions?
Everyone, so go ahead. Oh, sorry, go ahead.
I was just going to say, any other questions for our panelists?
Brittany, this is Danya. I have one little comment to make. I think it's really important for you all to recognize and keep a record of your own successes. I used to keep a little tickle file at my desk, and when something good happened, something that I felt warmed my heart and made me feel good, I wrote it down, just a sentence, because you'll forget these things if you don't. But you need to refer back and say, ah, that was wonderful. And that's what I had a part of. I always like to say, you know, with history, how do you know where you're going unless you know where you've been? And this gives you a little roadmap of where you've been with the successes that you'll need to pat yourself on the back. Just a thought.
I love that. I just wrote it down. That's such a good piece of advice, Danya. Thank you.
I have a quick question for you, Danya. So one of the things that showed up on your slide when you were speaking about your experience is that you have up to 11 medications that you're taking, and some of these are over the counter and supplements and prescriptions. Can you tell us a little bit about what it's like to manage those, or sort of what tips and tricks you use for that?
Yes, my husband will probably tell you that I'm always saying, goodness sakes, you need a doctoral degree to do this. I do use the little boxes and try to keep very careful, but it can be very confusing because of the names, and I don't know always, you know, what they're for. So I have to keep a list myself, but I have a list of all the doctors that I see and the medications that they've prescribed, so that if I go into the doctor's office, I just whip out this little piece of paper and say, this is me in a nutshell. But I guess you're wondering how to manage. I think so far I'm able to do it myself, but I think it is very confusing. When I was in the nursing home, they would bring all these pills and nobody would tell me what they were for. I said, I can't take this unless I know what it's for. And so I think it's very important that, you know, we just understand this medicine is for this and this is for that, and keep a record of it. I don't think that answered your question very well.
It did. Thank you very much. Something that you and I had talked about in prep for this session is that you're very organized. You have these lists, you know who your physicians are, you know who your what your medications are, and you bring them to your clinical encounters, but that you were pretty concerned that maybe most older adults are not doing that or unable to do that.
Yes, especially with when you're looking at the computer and all the technology that goes into the care. A lot of seniors don't even have a computer. I have to call my grandsons to ask them, how do I do this and how do I do that? But I think that you need to keep in mind that we're really very basic. Start from there
I do want to put out there, you brought up a good point. I do want to put it out there here at the Palmer Senior Center. I do help with the technology portion for the seniors here. I usually help about 2 seniors a day, and I sit there and spend about at least 1 to 3 hours with them, showing them about Zoom, emails, how to look stuff up on Google, just kind of how to navigate around not only the computer, but their phones as well. And so if you guys need or have somebody who needs help with technology, we are here at the Palmer Senior Center. And so you guys can always give out, have them reach out and refer them to us. And that's all I want to say about that.
Good.
Thank you so much, Jacqueline. That's an incredible resource. Are there any other final questions for our panelists? I can't quite see if folks are raising their hands, so just jump in. Okay, well, if there's none, I would like to go ahead and close out today's session with a warm thank you for everybody's thoughtful participation in a pretty important idea, and to put in a plug for our next session. So we do these twice a year. Our common theme this year is Eldercare. So our spring Grand Round session is scheduled for March 25th. Please mark your calendars. Same time, 11 a.m. to 1 p.m. This will be focused a bit more on improving quality of life and maybe hospital prevention type issues. We'll be speaking with some more of our allied health professions like dietitians and physical therapists as well. We've also lined up sort of a keynote speaker who has confirmed with us so far. She's a national speaker and author, a long-term geriatrician, so specifically focused her entire career on working only with older adults. She's also the author of the textbook I use in my aging classes. So I'm very excited to have her and want to put in a plug for the books that she's written, which include one called Eldercare, Redefining Aging, Transforming Medicine and Reimagining Life, as well as her earlier book, which is a history of the present illness. And it's a bunch of clinical encounters and stories, patient case studies, like we've talked a little bit about today. So I'm very excited to have her here next year. And I'm very excited if any of you are able to attend that session. Gloria, any final thoughts?
Just that registration for that one is not open yet. We will get on that in the beginning of the new year, so sometime early in the spring semester, just like you saw our advertisements and marketing out through faculty members and other venues. We will do the same. So you should see that and you will then be able to pre-register. But for now, if you want to mark your calendar so that you have that date set, you can go ahead and do so. We look forward to seeing you next time as well. And thank you so much for your attention, participation today. You've been a really great group.
Thank you to all the presenters.
Thank you, everyone.
Thank you so much.